staff. I'm actually filling in for Nitin, bless him. So some boots to fill because he's a lovely guy and I'm sure a lot of you know him. So yeah, I'll crack on. I'll share my screen and hopefully you'll be able to see what's going on. So we're going to talk about some lessons from the front line and all about COVID actually. There's quite a bit to say, but I'm going to compact it into well under half an hour, I hope, so you don't get too bored. And again, I suspect this has hit us more than the paediatric population, and indeed in our place it's been fantastic because the peds consultant and peds teams have been absolutely showering us with offers to help out. So we thank them immensely for that. You're just such a great bunch of people. Anyway, enough of that sharing of the love. We'll move on. So some horrible slides, and while you're looking at this disgusting stuff here, I just want to say that declarations that I have, do a lot of work with GE Healthcare, some with Baxter Healthcare, and some with Butterfly, but that's it. And obviously that thing behind you, I am the founder of, so do go and dig in and have a look around. Any links and things that are on here will be QR coded, so do scan them and take a look. So let's crack on. So COVID-19, I think you all know about it, but it is a blighter of a virus. It gets in via aerosolized droplets, sits in the lungs and distal airways, and causes havoc, damage, and effectively a pneumonitis. In doing so, it's killing off the alveolar cells, which it infects, and of course it docks via the ACE2 receptor. And we all know there are various mutations that are coming out now, which have a higher affinity for docking with this receptor, and hence the virulence goes up and so forth and so on. And of course, it hides itself in many different ways. It hides itself as a cough, shortness of breath, fever, headache, and of course these two here, which lots of us are learning about at the moment, are fairly unique, and it does cause some damage centrally, but temporarily causing anosmia and ageusia, so you know, your loss of sense of smell and taste. And indeed, some of our trainees have phoned up and said, I can't smell anymore and I can't taste anything. Well, you need to stay off, and indeed they've had COVID and they've tested positive, but a lot of them have just had this and they've had absolutely nothing else at all. So it is a very, very sinister cloak and dagger, I can hide as any other disease type illness virus, which is the problem, and we all know this. Kids at nurseries get a cough, they get sent home till they're swabbed and tested. Of course, it's probably just a cough and it's probably just children, but until you get the test, no go. So diarrhea as well, and nausea and vomiting. These are other things that this thing presents as. So when we get to the front door, we get lots of different situations occurring. So let's imagine this is the ED. So we'll start the pathway there. We operate effectively a traffic light system of red, amber, and green. So your greens are the, I'm walking in, chatting, I think I've got COVID, I'm not very well, might have a temperature. These guys here are pretty much dischargeable with further advice on further deterioration, come back in, etc. So we're not so worried about those guys. They need to go home and isolate, and indeed people around them do. Then we've got the amber posse who have sat sort of below 94%. A bit more of a worry this. And indeed, it's a bit difficult to send patients like this home. If you do, I think they're going to definitely and absolutely need home monitoring, and we will operate that at Northampton. Now, I don't know whether anyone is aware of that being an operation anywhere else, but it's quite effective. They're watched on a laptop overnight. Now, this lot here, you absolutely can't send them home. They're admitted, and indeed, some of those amber ones may be admitted too. So by the time you get into this point up here, you know, you're really going to need to be admitted because the further deterioration is very likely. But these guys here, you might be able to send them home with home monitoring, but not the ones on the top left by any stretch. Now this, you know, it's me, it's Johnny, yes, I'm POCUS mad and all that stuff. I do find POCUS extremely useful in COVID. And the reason is the environments we're in, particularly on the ICU, one of these things is absolutely useless to me, and I just can't hear anything except ventilator noise, and indeed the hustle and bustle around and about, and trying to communicate with everybody in PPE is an absolute nightmare. So I tend to go more for this sort of thing. The cart-based ultrasound system, and indeed a load of the handheld systems, they're amazing for this pandemic because you can clean them so easily, pull them out your pocket, make sure they're cleaned and covered and so forth. So, you know, again, why look at the exhaust pipe when you can look at the engine, you can see inside the body and see what's going on. And indeed, COVID manifests itself quite clearly on ultrasound. So there'll obviously be some bits about this in this talk. So the advantages of ultrasound for COVID, it's very sensitive, it's fast at the bedside, you can keep an eye on the disease progress, you don't need to transfer them out, no irradiation needed, and you don't need to be going to these venues here and taking the patient from a place of safety into a place of danger, and indeed, you don't need to go dirtying other venues that were previously clean. Now, we've got a decision pathway we came up with at Northampton. This was done by myself and some of the respiratory team and the ICU team. And essentially, it follows the patient from admission at the top, and we go from here with the various tests and so forth and decision-making processes. Happy to share this with people, by the way, to the O2 decision tree, right to the bottom, and it follows us through to escalation to ICU or not. And the sad thing about this is many patients are not suitable for escalation. It's very important to identify frailty scoring and identify those who, if pushed too far, they're going to have a really, really nasty time. And indeed, you'll have read in the media that this is one of the biggest and most controversial areas at the moment, with this pandemic surging and people and units being completely overwhelmed. The media and indeed lawyers may be coming for us for decision-making processes they believe to be wrong. And there is NHSE support for this, and it is a really, really tough time for everybody. But again, your ultrasound can come in at the front door during oxygen decision trees, and certainly on the ICU when you're deciding on further treatment. So we'll talk about this in a minute. So here we go. We've got your man. What you do is you put your ultrasound probe on the anterior sections of the chest. Then you put them down at the bottom or the PLAPS point at 3 and 4. And you can see here, you can even do it in a proned patient, and we'll talk about that in a second. So wherever you place your stethoscope, you can place your ultrasound probe, and you're indeed seeing these different parts of the lung, and indeed not missing any for that matter. And again, COVID pneumonitis is a peripheral beast, and it starts to affect the peripheries first before we get more central problems. So it is pick-upable on ultrasound. And we're looking for interstitial fluid. Now, I must add now, COVID does not cause instantly ARDS. COVID does not equal ARDS. And Gattinoni goes on about this to quite some length, and he's correct. It is a pneumonitis, and it is very similar to patients who've had chemotherapy. They develop pneumonitis. It's similar to aspiration pneumonitis, and indeed any other viral pneumonitis. Now, normal lungs look like this. Really nice stuff here from Curo Morales, and I pinched these from him, and thanks to him. You can see here, pleura and A-line reflection profile. This is air, and it doesn't allow the sound waves through very well. But you can see transmission down, rib, and normal lung. Here's your A-lines, so that's what we're viewing. That's a normal situation, a nice dry lung. So you might see this in the guys who are walking in, talking, and not complaining of much. Go home, isolate, and so forth. When we start to develop further disease, you can see here, this is entirely different, pleura, and these laser beam structures called B-lines traveling right down to the bottom of the screen in their entirety. If they're broken, they are not B-lines, okay? Now, that's caused by the allowance of sound waves to travel through fluid, i.e. pneumonitis caused by the virus. And this pleura starts to change as well, and you'll see that in a moment. So the guys you're seeing like this might be these lot, eminently doable, that you can have this and still walk home and be isolating. But you could have a temperature and be feeling quite dodgy, and it's likely that's going to be the case if you're seeing that image on the left side. Moving on, we're seeing worsening of this B-line pattern, and there are so many here, you're getting confluence, and it looks like cardiogenic pulmonary edema. There is so much whiteness there, but these are in fact individual B-lines that multiplied together to cause total whiteness, and the sound waves love to travel through that fluid. And you can see that there. These guys are likely to be like this, and indeed likely to be even worse. Clapped out, collapsing, and in quite a bad state. Now, sometimes you don't hear anything with your stethoscope, even when you're seeing this, and it is a very sensitive thing to see on ultrasound. Chest X-ray may pick up nothing, but you're seeing it on your ultrasound. COVID isn't technically associated with pleural effusions at the basis. However, it does get associated with consolidation, and this is sort of an area of shred. And you can see the pleura is almost not visible, and this is indeed towards the bottom. But this is all consolidation and gackiness, and it could have superadded bacterial infection within this, and again, whiteness below it. So the pleura is probably being dragged down here, and subpleural consolidation is visible. These guys are very unwell. It's very unlikely you're going to be going home with a situation like that on your ultrasound. But again, sometimes chest X-ray will not demonstrate this. And on this one, even worse, this is a basal point down the right axilla. And here we can see Dynamic air, fluid bronchograms, very nasty gacky lungs. Here's the diaphragm. Patient's head would be here, patient's feet would be here. But this is a horrible base of the lung, full of consolidation. I reckon superadded bacterial infection. We see this quite often. These patients are going to be sick. Now, there are these phenotypes that were brought through, the L type and the H type. Now, we don't really harp on about this too much these days. We did in wave 1, but in wave 2, not so interested, but it is relevant, and I'll explain why. So you've got type L and type H phenotypes, and these were described by Gattinoni. And what they're saying essentially is these are different CT, so computer tomographic appearances. On the left, you can see the lung is relatively spared, but you do see an area here which is picked up on the ultrasound, and that is a peripheral pneumonitic area there and some consolidation. Again, put the probe on here and you can eminently pick up changes on that section. The rest might be normal, but this one, you know, this is a supine patient on the ICU. You can see loads of posterior consolidation, and hence proning patients and flipping them over. You can see why this may be of help when we rotate them, and that fluid distributes itself further towards the front, allowing gas exchange at the back sections there. So what are these phenotypes? What does it mean? Well, the L phenotype is a low elastance, and that means a high compliance of the lung. So ventilating, squeezing the bag, it's okay. You can get gas in and out. So the amount of non-aerated tissue is low and recruitability is low. So that means that PEEP's not going to be that useful. You've got a low VQ ratio, and that means that hypoxia might actually be due to perfusion regulation loss and hypoxic vasoconstriction going on. You've got low lung weight, and you can see that on those scans. Subpleural ground glass opacities on the scan, it only really moderately changes the lung weight, so you've got a lot that's ventilatable. And the low recruitability, again, nearly normal amount of gas in the lungs, so whacking high levels of PEEP on is going to compromise the circulation. Don't do it. That's the implication of the L phenotype, early-ish. The H phenotype, you've got a high elastance and the reverse low compliance. Now this time, you've got a lot of edema, and you've got decreased gas volumes and an increase in lung elastance. You've got a high right to left shunt, and that's due to the fraction of cardiac output perfusing non-aerated areas of lung. It's wasted cardiac output. You've got a high lung weight, remarkable increase in lung weight seen, and indeed on post-mortem, these lungs are soaked and they're very heavy. It's very sad. High recruitability, so this is where we can get our PEEP involved to improve our VQ ratios and indeed improve our arterial oxygen saturations. So, you know, at that stage, yes, PEEP is okay, and you may need higher levels, but go ploughing PEEP in very early on in the guys who've got the L phenotype, it might do them a disservice. Now, if you scan this, you'll be able to it'll take you to this page. Now, APRV, assisted pressure release ventilation, has become very trendy during COVID. Now, it usually relies on the patient spontaneously breathing. And what we do is we set a top pressure or a P high, and the patient then breathes during that pressure. We then set a P low, which is usually 0. That allows them to exhale. And then the same thing occurs again. So if you paralyze the patient, you're just holding the lungs expanded, but there's no oscillation going on. Gas exchange can be, can get worse. So this is what APRV is, effectively 2 levels, a top and a bottom. Patient breathes up the top, breathes at the bottom, breathes up the top again. And it is all there to improve expansion and recruitable areas of the lung. And it does work in some patients. However, there is little evidence about APRV, full stop. There is certainly little evidence in COVID, but anecdotally we see, excuse me, that it can work. And equally, proning our patients. And you can download this. This is a checklist for proning. And that, again, looking at those CTs, you can understand how redistribution of fluid can improve our gas exchange. So we're doing a lot of proning. And indeed, importantly, during wave 2, we know now that self-proning of patients who are, for example, receiving non-invasive forms of ventilation on the CPAP wards is very beneficial and really does work. Now then, Daniel Lichtenstein came up with the Blue protocol, and here it is. And this is all about lung scanning. I've adapted it for COVID slightly for you. So if you have a look here, this is the Blue protocol, and it starts with lung sliding and all the images you've seen, but the important parts are coming in a second. So if you've got B lines appearing, and they're quite widely spaced out with areas of normality in between that you can see down here, then this is where diuretics and potentially PEEP come in depending on what's going on. So you can help them with diuretics and PEEP. Now I must add here, please do not under any circumstances overload these patients with IV fluid. We hate this because it will just cause extravascular lung water and pneumonitic changes, and they will worsen. So we've got to be damn careful what we do with fluids. And all COVID patients are not automatically hypovolemic, as often assumed wrongly. By the time we get down to this consolidation and pneumonia at the bottom, this is where proning can come in very useful. And you can see again, there's horrible changes at the bases, but that's usually quite late. And then, of course, the next thing we need to think about, very high on the agenda, is pulmonary edema. Now, those B lines coming into confluence could be the heart. Let's not forget the heart. The heart and the lungs are in interaction. So you'd be stupid to think that the heart is not involved here. So please do scan the heart, make sure that there is no COVID-induced cardiomyopathy, septic cardiomyopathy, or myocarditis, because it will cause heart failure. And you can see that on that image there. In this situation, again, diuretics come in. So you can see that diuretic therapy has become quite high on the agenda for lots of our patients. And euvolemia is the key, not massively negative anymore. We got a bit bonkers in the first wave, getting them too negative. Euvolemia is the key. You might need dobutamine or other forms of some trickery with some inotropic agents to help you out. Another massive thing with COVID is this. If you have a DVT and cardiac problems, there is a PE, full stop. There can't be anything else. And indeed, this causes, it is a very thrombotic process, this COVID disease. And we've seen on post-mortem examinations, microthrombi throughout all the lungs. So we must consider PE, and hence all these VQ scans going on and CTPAs going on, the demand for that has increased exponentially. But ultrasound can pick it up, of course. High index of suspicion. Here is McConnell's sign demonstrated, and you can see an area of the apex, which is contracting nicely there, but the bases are not on the right side of the heart, and this is dilated. There's a high acute change in pressure. That's McConnell's sign, and it's pathognomonic of a PE on ultrasound. So in that circumstance, you may need, in fact, treatment dose anticoagulation and indeed noradrenaline to help them. Don't overload these guys with fluid, because that RV in the right side and venous return is already huge. So you've got to be very careful and do this carefully with offloading as well. So really that's it from the ultrasound point of view, but it is pretty handy to help you out with your patients. Right, so some quick examples of what you might see. Here we have a long axis view of the heart, you know, good contractility and things like that. There's no real issue here, no massive pleural effusion behind here. So this is all fine. However, when we scan the lungs, I think you guys may have picked this up from before now. You can see that there are multiples of B lines coming through, but normality in between with A line profiling. So the air is allowed through here, but these areas of lung are not normal, and this pleura is starting to thicken up, and COVID causes pleural thickening. The other side of the chest, there are multiple B lines there, and you can hardly see any A lines at all on that one. And indeed, further down here, if you look carefully, this is a subpleural consolidation going on here. Just there, you can see an area of subpleural consolidation, and again, more B line profiling. So this was a patient that was fairly sick, actually, but on non-invasive ventilation, not intubated. So you monitor their disease, dry them out, and help them. Unfortunately, this sort of circumstance happens quite often, and you can see a very dilated, poorly contracting left ventricle, and you see the anterior leaflet of the mitral valve. They're hardly getting anywhere near that septum at all. So this is bonkers. This is myocarditis. This is likely COVID-induced myocarditis or septic cardiomyopathy. Massive care needed here. And if you look at the back there, because there's a lot of blackness behind that thoracic aorta, not in front. If there's fluid in front, it's a pericardial effusion. Behind, it's pleural. This patient's in a bad state. Here's your view of the lung. You've got subpleural consolidation coming in here, multiple B-line patterns, and a high respiratory rate with thickened pleura. Classic COVID. So we've got a cardiac issue, and we've got the pneumonitis going on with all these B-lines coming down here. They are rife. They're all down the screen. Really not a good situation. And this is the base. The patient's head is here, and the patient's feet are down the bottom. Here is the spleen, and this is the left side. Now, you see the spine at the back there? In the abdomen, in that abdominal section, you can see the spine. You are not supposed to see the spine when you get into the thoracic cavity, because this should be full of air, but this is consolidated, echo bright lung, almost the same texture as the liver. And you've got a small pleural effusion, could arguably be a bit of fluid in the abdomen there, but I think it's pleural effusion, and a very sick, ventilated patient. And again, just another example so you get familiar with these scans, and I will, for you all, upload this talk to YouTube so you can all download it. That's the plan. More B-line profiling, thickened pleura, but it's oscillating left and right. So there's no pneumothorax there because we're seeing a lot of pneumothoraces in these patients. That pleura would be static and still, it wouldn't be sliding. We're also seeing a lot of pneumomediastinum in them. Now, this is the IVC. This is very plethoric and dilated, 1, 2, 3 centimeters. So very high right-sided pressures here, and they're probably overloaded somewhere else and need indeed diuretic therapy. And if we did the Vexus thing I talked about some time ago, we'd see that they'd be casted. And again, base of the lung here, awfully consolidated, small pleural effusion at the back there. So a very sick patient. Right, so enough of that ultrasound bit. What we got next? This bit here was a talk I gave some time ago, and one of our friends from the US summarized it in a very nice infographic. So when you're thinking about fluid in these patients, be careful. You need to assess volume tolerance because they have decreased volume tolerance. And what that means is if you gave them a litre of fluid, the likelihood is their pneumonitis would worsen. Similarly, cardiac output may be dropped due to myocarditis and pericarditis. Venous return may be down because they're vasodilated. They have capillary leakage and high intrathoracic pressures. When you evaluate them, yes, if you can, use ultrasound, it's very helpful. And also assess the heart-lung interaction. And Vexus, if your IVC is above 2 centimeters, you can progress on and see if they've got congestion, looking at portal flows and hepatic venous flows and so forth. Again, there's a talk about that I delivered last time, which is up on YouTube, which you can download. And so be careful. And these mini fluid challenges are the key. Give small amounts, reassess, do a passive leg raise test, see if they're going to be any more volume tolerant to give a little bit more fluid, but be careful. Euvolemia is the key and diurease them early. Don't overdo it because they'll then go into multi-organ failure and need CVVH and renal support. Be careful, but don't give too much fluid. Lots to see here. This is Yali Tung Chen, an ED consultant from Spain, and he was a bit of a hero, and he diarized his entire journey through COVID. He got COVID, bless him, and he takes us through from the top here where it started, where he's normal, and you can see here, normal, normal. Then he starts to get pleural thickening, B-lines appearing all the way through, and then it gets worse. His SATs drop, and at this point, he's got tummy ache and diarrhea, breathlessness, so COVID, very bizarre symptoms and signs. Then it gets a bit worse, and he actually develops some small pleural effusions at the bases by the time he gets here, but loads of persistent B-lines. And I want you to remember this. When he recovered, he still has significant changes with little comets and B-lines that come off the pleura. His pleura is not back to normal. So what we're seeing in patients who do recover, even if they're really fit and well, some of them have this band of tightness across the chest they'll describe, pain, and a T-shaped bit of pain down the trachea and across the top of the chest. And if you scan these guys, which I've done multiple times in well people who've got over COVID, they still have lung changes on ultrasound, but normal chest x-rays. Now then, nearly there. What about wave 2? So what's different? What have we learned this time? Well, we know there are more mutations and this virus is more virulent. There's a vaccine out, we'll go into that in a minute, but the transmission is higher. And it indeed has different vectors and so forth, but there are greater numbers of patients. The vector set, yes, pediatrics come in here because the primary school age children transmit it, but are fine. Secondary school, it gets even worse. They carry it, transmit it, they're fine. By the time you get to university and everyone going bonkers there because they're away from their parents, even worse. So hence you can see all the rulings of closing schools and so forth is so important. Single organ failure versus multi, we're seeing more just chest initially. So they're being managed a lot more on the CPAP wards with non-invasive forms of ventilation, and we're allowing them to go to 90% oxygen over 10 of PEEP, and we're leaving them there for a bit and seeing how they get on. Then we're scooping and running as and when we think they need it. Less multi-organ failure, but by the time you're getting renal failure needing support, the mortality goes way up exponentially. There are more females this time. The patients are younger. We've had a 22-year-old who had this disease but recovered and got out, but 22 years old, and they were sick enough to be tubed. And we've also got ethnic minority groups as well being affected as we did the first time. So it's very sad. Now, if you look at this, here is the run chart for what happened with the virus. First lockdown kicks in 23rd of March, ends 10th of May. And you can see what effect that had. The viral numbers of infected cases dropped drastically. Then, of course, We all went bonkers again. Everyone forgot about social distancing and not wearing masks and so forth. It went up and it went, oh God, here we go again. So another lockdown was instilled on the 5th of November. And again, that had a drastic effect and things dropped and it came down. But the mutations were starting to come in now. And of course, we're now up here. 88 to 89,000 cases in the UK as reported today, I think it was. So these numbers are massive. We need this lockdown. We need to behave. We need to educate people. And you may have seen Hugh Montgomery on the news telling everybody that they've got to be careful, they've got to wear masks. And in fact, he said there'll be blood on your hands if you don't. And he's right to a degree. So all this scaremongering in the media and things, to be honest, I think some of it's well placed because this is an absolute nightmare. And it's having a huge, huge impact on our hospital beds. And if you look at that graph, you would see the inverse for availability of hospital and ICU beds now. And we all know our hospitals are absolutely jammed to the rafters with patients coming in who are sick. And our ICUs are not coping. We're taking patients from all over the country. We're repatriating eventually, hopefully, but we are decompressing multiple units around the UK if there's bed availability. So we're all sharing in the love, but we're all suffering massively. Our staff are suffering and there's a lot of burnout. And indeed, the staff aren't as available as first time because we took too long to cancel unnecessary elective cases. We've got to keep cancer going, but I think we took too long to cancel many of those, so people were still working, getting tired, picking up COVID and so forth. Staff base drops, stress goes up, less availability of beds, even though they're sitting there because you can't staff them. So these are the differences this time. But let's encourage staff back, pay them better. We've got better PPE now, it's more available and it's more comfortable. We've got better understanding of the processes, diseases, and we've got real good drills going on how to do things, how to scoot and run with patients, how to prone, and what the COVID intubations entail, and how to leave them more and just relax a bit when they're on non-invasive ventilation, because that works, and many of them get out with just that. Again, slicker with our processes. But I think, having said this, we have got more on the CPAP wards, more non-invasively ventilated. We are now, I think, starting to jump in a bit earlier and bring them into ICU, because the first time around we were really panicky that intubating them was going to put the mortality up here, when in fact it could be just down here on non-invasive forms of ventilation. But I think now we're just getting in a bit earlier. There's a younger cohort of patients and they seem to fall off the perches a lot quicker this time. Again, it may be the mutation. Staff availability, I've just discussed this, but we need to pay them and give them incentives. Stress levels, they're through the roof. And you'll have read articles about nursing staff who just can't come in anymore. You may know of colleagues who are really stressed and are burning out. It's a real issue and I feel for everybody. Now, the vaccine, yeah, well, it depends what your trusts are offering. We've been very, very lucky at Northampton. We are on the Pfizer vaccine, 2 doses. Yes, it's gone from a 3-week gap in between first and second to 3 months. We could argue to kingdom come about all of that. Oxford's out now, which is great, but they all are very efficacious. And indeed, even if there is just a first dose and then a second, take the first. Because, you know, you're not going to turn into a chicken and go clucking around. You're not going to develop another head. I think there's been a lot of scaremongering in the press and things about the vaccine, but it's effective. So please go for it. There are lots of different types. But essentially, the mRNA vaccines utilize your cells to make spike proteins, which are similar to the strains of COVID. And indeed Oxford, the common cold through chimps and a bit of a genetic modification. Your body then mounts an antibody response. Just get it done. Please get the vaccine. Loads of research, phase 3 trials. Look at all this. Everyone's trying everything. There was ivermectin, you know, the anti-helminthic drug. There's been all manner of crazy stuff going on, but there are some very encouraging phase 3 trials going on with lots of different things and lots of different strategies for COVID. And I've never ever seen so many phase 3 trials going on, and I've never seen peer review processes so rapid and so many papers coming through on COVID. But we know about the recovery trial. Dexamethasone is very effective. If you come in, you're ill and you need supplemental oxygen, get 6 milligrams of Dex started, carry it on for 10 days. That works. It decreases mortality. Now this one, hydrocortisone, 50 QDS high dose versus placebo. They didn't really see a mortality benefit, but the Bayesian analysis on the trials have shown that there might actually be a bit of a benefit to it. And we all know, we're very familiar with giving this stuff on the ICU. There may be some benefit, but Dex works better than that one. These are all from the bottom line, by the way, and you must check them out because they're great. Now, tocilizumab, the first trials that were done into this, the patients weren't really that sick. They were on non-invasive ventilation and stuff. And REMAP-CAP has been looking at all of this. And so the results were sort of equivocal as to whether this worked. So that was chucked out first time round. But now REMAP-CAP has revealed that these IL-6 antagonists are actually very beneficial and can decrease mortality in the sick group of patients. So this is now coming in, and I'm sure your trusts are trying to stock up in pharmacy for these drugs. That is it. So we've gone through ultrasound assessment at the front door right to the ICU. We've gone through why wave 2 is different to wave 1. And I think the bottom line is that we're all here to support each other, and you guys are pivotal because you are extremely good in the paediatric world at dealing with sick patients. Indeed, you deal with sicker ones than us, and more scary patients for that matter. But please take care, support each other, and we will get through this eventually, but we must get the vaccine and we must follow all of the governmental guidelines, because otherwise we're going to be in a world of pain as we have no beds left at all. So I thank you for listening, and Zafar, thank you very much for inviting me.